are in listen-only mode.
Well, good morning. This is Craig Talbert. I'm president of the Alabama chapter, and I wanted to welcome you to our Region 5 webinar. Today we'll be talking about building for the value era, payment evolution, and care redesign. So glad you were able to join us. Just a couple of quick announcements in regard to our webinar and process. On your dashboard there, you'll see an area where you can ask questions. So feel free to type in a question, and we'll keep track of those, and we'll probably answer those at the end of the presentation. If you raise your hand and have any kind of issue with audio or visual or anything like that, just click the button there to raise your hand for an issue there, and we'll try to resolve that as quick as we can. So without that, I will go ahead and introduce our speaker. Today we have Jeff Moser, Vice President with SG2. Jeff provides thought leadership at SG2 by preparing clients for the shift to value-centric care and plays a key role in supporting the development of SG2 intelligence resources and educational offerings. Jeff is a frequent presenter, educator, and author on multiple topics, including policy and healthcare reform, accountability, ambulatory strategy, patient engagement, margin management, and leading practices in care redesign. Jeff has over 18 years of healthcare consulting experience with specific areas of expertise including care redesign, strategic planning, process improvement, operational effectiveness, training and development, organizational change, and the development of care systems. Prior to joining SG2, Jeff serves as the Vice President of Assessments at Cardinal Health in Dublin, Ohio. In addition to directing Cardinal Health projects, Jeff identified opportunities for improvement and recommended specific strategies to client organizations. Prior to Cardinal Health, he served as project director for West Hudson, Inc., which is now also part of Cardinal Health. Jeff received an MS in organizational psychology from Springfield College in Massachusetts and a BS in both economics and psychology from Texas Christian University. So, Jeff, I'll turn it over to you.
Thanks, Craig. Appreciate it. And unfortunately, TCU did not make it into the my brackets. Their horrible basketball team did not make it. But I hope you all are keeping an eye on the tournament as it gets rolled out, and hope this isn't a distraction to the fun events this afternoon that'll start in just a few hours here. But thank you for spending some time with me today on this this interesting topic around payment evolution and care redesign. How I thought we would spend our time today, and considering the audience, I think probably this first section will be, I'll try to keep it fairly efficient, but we'll get into a little bit of what's going on across the nation by way of payment evolution, what's a little bit maybe behind that, if you will, where is that leading the industry. And I think probably more interesting to you all, more interesting to me, is the second bullet here, which is how is the industry responding to this? So what I tried to do is cherry pick out a few initiatives that I see across the country that are happening that are redesigning care, and that seems to be the focus, redesigning care, in order to prepare for the shift to risk and payment risk and the tenets of value. So again, as Craig mentioned, if you've got questions, feel free to type them in as we go, and I'll try to get to as many of them as I can at the end of the presentation. We have about an hour and 20 minutes scheduled or so, and I think the presentation component of this, hopefully I'll keep it around an hour or so to leave plenty of time for questions. So with that, why don't we kind of jump into it, and I'll start with just a little bit of a level set to say, number one, maybe you all may be considering retiring when you look at lists like this and you hear from people like me, and we talk about all the things, all the balls that are up in the air, all the things you're juggling, all the things that are keeping you proverbially awake at night. And they run the gamut, and they are complex, and we are definitely in transition in healthcare. And, you know, again, I'm not going to necessarily read through this list. I will hit on a couple of these, and I have some examples of some of these things, especially related to tiered and narrow networks and how they're moving into some markets fairly rapidly and changing the dynamics within these markets and pushing market share pretty quickly and pretty quickly, I would say within 8 months or to a year or so. So maybe not exceptionally rapid, but quick enough that we want to pay attention to it. IT implementation, of course, you all live and breathe this every day in terms of how to finance this, and it is causing significant consternation with most of SG2's clients in terms of how do you finance this, how do you find the capital to allocate effectively with this, and more importantly, how do you roll it out effectively without spinning your wheels and burning political capital as well. And ultimately, sequestration, policy, politics, and budgets keeping you all up at night. And clearly and truly, I think we are living in interesting times in healthcare. I'll be a little cute here for just as we get started and let you know that I looked this up. May you live in interesting times, and some of you may know that is an ancient Chinese curse. So in healthcare, I guess we are cursed, and we're cursed because we live in interesting times. When I looked at that proverb and curse, it was interesting because it's actually one of three escalating curses, cursi, if you will. And the second, so we've been cursed once. The second curse is, if you all could guess, is may the government become aware of you. So perhaps in healthcare we've been cursed dually, because the government is definitely aware of us. And if I had to read the tea leaves and go back and say maybe back to 2007, 2008, when they first kind of started putting in, and formalizing this report through the Congressional Budget Office, they started to look at waste and value in the system across healthcare, and they characterized it for us and basically came to the conclusion that about 30 to 40% in some studies even of what we do day in, day out in healthcare is wasteful. It was further characterized as provider error, unnecessary care, readmissions, avoidable conditions, and the lack of really building a system of care and coordinating care across the continuum. I think this is interesting, and to me it was a little bit of a bellwether study, because if you think about the Affordable Care Act, really, number one, it was about expanding coverage and expanding insurance, but I think equally it was about pulling that waste then out of the system. So you see that embedded throughout the different milestones across the healthcare reform timeline. So be it the bundled payment experiments and pilots, medical home demonstrations, penalties that you all are well aware of now under the readmission side, value-based purchasing, paying for primary care to help coordinate that care more effectively, and of course, as you all probably have been paying attention to, this movement towards accountable care organizations, and whether or not this is going to continue or not, we'll discuss that a little bit later. But I think to me, that's an important aspect of the Affordable Care Act that may be overlooked in some cases. Is it's really also not only about insurance expansion, but it's equally about redesigning care and pulling waste out of our system. One of the other things that I think is interesting from the Affordable Care Act's perspective is the idea of the insurance exchanges. And for us at SG2, we really consider this one of those sleeper issues that it isn't maybe talked about as much as it should. And I had the chance to participate in a conference in about November of 2012, and there was a panel there that was all payers. So it was Aetna, it was Humana, it was Blue Shield of California, and I forget the fourth payer that was there, but they were asked the question whether or not they were going to participate and offer products onto the exchange. And invariably, all of them kind of came to the conclusion of, yes, we probably are. We're taking it kind of region by region and area by area, state by state, to see whether or not this is a good play for us. The one consensus that I heard from all of them was that they recognize that if they put something out there, the pricing around these are going to be less than what they're pricing commercial products currently. And they really threw out a number about 12 to 16% less. So I think good news and bad news for you all. Good news being that, well, we probably, a lot of these patients were self-pay, and and even charity care in some instances. So we're going to get something. However, it will probably be less than what we normally would expect for our commercial rates, and the price sensitivity in the long term will likely lead to added pressure from the payer's perspective that will be translated to lower rates for you all on in a given contract period. The other component to the state exchanges that we're paying attention to is this study that came out through the Kaiser Family Foundation, where they looked at kind of pent-up demand and how people would characterize their conditions currently. And they went back to 2007, but I think it's still relevant for today and for 2019. And that was, and I know this is a little bit busy a slide, so let me acclimate you to it real quickly. If you look on the far right, what you're looking at is the uninsured population in 2007, and in column 1, chronic condition, we're looking at, as an example, the third row down, percentage of patients that report 3 or more chronic conditions. And in 2007, uninsured patients reported about 8% had 3 or more chronic conditions, compared to 2007 employer-sponsored plan, the third column there, where 15% of the population would say they have 3 or more chronic conditions. So what they're thinking at the Kaiser family is that there's a pent-up demand for services, and these patients, as they become more and more educated on their diseases that they currently have, will start to access care. The troubling thing for all of us, and for you, I believe, is that these conditions are chronic, and these conditions are difficult to manage, and in most cases these conditions have very limited margin exposure. So do you want these patients filling up your beds, or do you need to build a system to keep them out of the hospital, activate them in their care, but generally speaking, avoid ED visits with these types of with some of these types of patients? So I think that that gives us a little bit of time to build it, but this is all happening again within 2014, 2015, 2016. So not a ton of time to move on this to build out those access points across our ambulatory continuum of care. So we put this slide together a while back, and I think it's still relevant to all of you in terms of what this translates. So if you think about the impact of reform, you think about the impact of the commercial market moving, the exchanges, the Medicaid expansions, you name it, that you're dealing with. How does that translate for you all? I'd say right now most healthcare systems, and I do a lot of board retreats and a lot of presentations across the country and meet with a lot of you consistently over the course of the year, and I would say that for most of us, we have built a model that's been successful, and it's been focused primarily on the inpatient business. We've done a good job of securing and building strong physician referral channels. For the most part, the ED is the front door, and we've done a lot of we've spent a lot of time cleaning up our EDs, updating our EDs, making them very accessible. We've advertised on billboards, even in some cases, to say how easy our ED is to access, come one, come all. And it's been a revenue center for us, and I'm not making a judgment on the strategy. That's just kind of the reality of today. We've done a good job of managing revenue cycle. Length of stay has come down across the board in most facilities over the years. Because of the reimbursement system, we haven't really been incented to link our system of care together in any meaningful way. So ambulatory has been walled off to the acute center, and post-acute has been walled off, and they're all separate business units and separate business models and managed very discreetly. And that's, again, just the reality of the situation today. Because of that, there's a lot of inappropriate utilization, a lot of readmissions across the system, and we're starting to see some penalties come to bear for not managing those more effectively. And you all, as CFOs and finance folks, have done a wonderful job of pushing cost reduction unilaterally, in some cases, across the departments and across the cost centers, and have pulled out significant costs to the system, on average, let's say 5% per year. That was a successful strategy for most of us. In fact, the dirty little secret that at least I've been picking up on when I do board retreats is invariably the CEO will come up to me before we get started and say, in kind of a whispered, hushed tone, Jeff, guess what? we had the best year ever. Shh, don't tell anyone. And I think that's the case for a lot of us out there. Our EDs are growing. Our inpatient is flat or still growing. And we've been profitable, and the physicians are happy. And for a number of us, in especially smaller communities, we won the best employer. We are the largest employer in town, and everyone's generally happy. We haven't been penalized at all in any meaningful way for the weaker aspects of our performance. Now, so that's the close of the books of 2012. If we fast forward just a few years to 2016, the picture looks a lot different because of the dynamics of the penalties embedded in the Affordable Care Act, as well as what the commercial industry is pushing us to do. So as an example, I was down in the South. I grew up in Louisiana. I was down in Louisiana a few months ago and meeting with the CEO down there, and he was talking to me about that they hadn't really got going with any of their strategies for readmissions or overutilization yet, but they were very concerned about it. And in fact, in this hospital, about 70% of their revenue was tied to Medicare. So if this hospital chose not to do anything about readmissions, then CMS would all of a sudden put at risk about 5% of their overall Medicare revenue. So for them, let's say they ran a 4% margin, 5% on the 70% almost overnight wipes that margin out. They would also be excluded from private payer preferred networks, tiered networks, narrow networks, because their costs are too high. Maybe their quality isn't up to snuff. The patients, like myself, who may be in a high deductible plan, are paying very close attention and shopping their care to manage their out-of-pocket liability. And even the primary care physicians that may have gone to school with some of your specialists are starting to break away and just saying, look, in 2016, I'm under a different type of reimbursement structure now, and I can't refer to you until you get your cost, until you get your quality lined up more effectively. So for hospitals across the country, doing nothing really isn't an option, because at the end of the day, in 2016, profitability market share starts eroding very rapidly, and it would even begin before 2016. But in the case of this hospital in Louisiana, they would be in a dire situation if they didn't do anything until 2016 to work on change and managing change. That said, I think most of the markets that we see will evolve and develop towards accountability, but towards risk-based contracting at different paces. And I think that's a good news story, because definitely for most of us, for all of us, I'd say, healthcare is local. Our communities are local. They access and see you all in different ways, as different resources in your communities. And I think that's important, that we manage the pace of change based on the dynamics of our market. And you can see from the graph here where so the darker the shade, the more ready or more the appetite for change towards risk, shifting towards risk, is greater than the areas that are colored clear and white, where there's just not a lot of movement yet by way of medical homes, by way of ACO experimentation, by way of narrow networks or anything else that would move the market more quickly. So again, I think that's a good story, that we have time to develop local strategies and fit into the dynamics of the market. As that shift occurs, and putting it in context of that second slide that I showed relative to waste, all of the emerging payment and care delivery models that we're keeping track of, be it pilot programs through the Innovation Center of CMS, also bundled payments and the pilots therein, medical homes that you all may have some experience and exposure to, as well as ACOs and high deductible out-of-pocket plans. All of the objectives of those things seem to be pretty consistent, and it's about pulling that waste out of the system and improving care coordinating and incenting people to coordinate care more effectively, more systematically across our communities. My mom, I like this slide, and I like to pick on my mother. She has no idea what's going on in healthcare, and she has no idea what I do for a living, for that matter, either. And I like to going to be a dork and take this slide with me to meet with her over Thanksgiving dinner or what have you, because I think this boils it down pretty easily and makes it digestible for all of us as to what we're trying to accomplish with this shift towards actuarial risk and to value. Historically, what you see on the green bullets is something that we've done very well, and we can do this, and we have control over it as healthcare providers, as physicians, or as administrators within our facilities. We can help manage the cost, and we'll use back pain as an example. We can help manage the cost of back pain. We can choose expensive implants. We can choose less costly implants. We can also manage, and we've done, again, a good job of this. We can manage the number of services per episode, so we can treat something conservatively. We can put somebody into rehab for a duration of time to try to mitigate our surgical procedure volumes. If that's in our best interest, we can do those things. So we can answer yes to the questions of can we do something about the number of services per episode. Now, when we get into the blue, it gets a little bit more complicated, and this again is what is our challenge as we move towards value, and it is, can we manage the number of episodes per condition? So let's say I have back pain, and I throw my back out, and I actually do throw my back out fairly regularly, at least a few times a year. Can you control how many times I personally come to your ED? And a lot of us, in fact, when I'm meeting with folks across the country, they would say, yes, I can do something about that. I think that's maybe overly optimistic, and it's going to be problematic for a lot of us to say, yes, we can mitigate the number of times I come to your ED by different strategies of education, by outreach, by individualized treatment plans, etc. Further complicating this would be, can you do something about the number of conditions per person? Or simply put, how many people in your community have back pain, and can you do something about that? Can you systematically change the health in your community to avoid back pain altogether? And again, if you're moving towards taking on full risk, and you're moving into, let's say, an ACO model that's not founded on maybe fee-for-service, but really looking at capitation, you're saying that, yes, you can do something about that. And again, I think that's a risky move for a lot of organizations that may be less prepared than they think to do that. Now, complicate that further by saying this isn't just about back pain, of course. This is about any disease, all disease, that we have some level of control that are preventable in terms of hospitalizations, perhaps. So which of the new economic structures will work and enable us to redesign the work? I think all of them have their merit. So right now we're in the DRG world primarily as we transition more towards value-based purchasing, bundled episodes. It gets more complicated in terms of pulling it off. It also invariably involves us taking on more risk. So ultimately, are we heading towards global capitation or some variation of therein? I'd say the movement towards the idea of accountable care organizations is an interesting one to follow, and I follow it pretty closely. And right now, with the 100 and so odd participants in the ACO experiment covering close to 5 million Medicare lives, we're already at roughly 10% of the population of Medicare patients under an ACO experiment. So if that momentum continues, it will be interesting to watch. And frankly, is this just a stepping stone into something greater, and are we ultimately heading towards capitation? We'll see. I think probably some hybrid model may evolve and emerge that moves us in the interim. So we're paying close attention to that. In addition to the government structures, we're seeing some movement from the commercial side, pushing communities pretty quickly into value. So this is an example from Massachusetts, where in 2006 they mandated, as part of the legislation, that all organizations would be tiered into 3 tiers: high quality, low cost being the first tier, on down to tier 3, which would be either high cost and low quality, or some variation of the two. When we started to look at it, though, it was interesting, because what did it really come down to? at the end of the day, it came down to price. And why do I say that? Because the quality benchmarks were set so low that everybody met them. So really, overnight, what happened is there was a pricing transparency that took place in the Massachusetts market, so you could see and have visibility to how much your competitor was being paid on the different plans, Humana, Blue Cross, Blue Shield, Aetna, you name it. So the transparency didn't stop there either. Of course, the payers picked up on it too and started to use that as leverage to pressure perhaps those providers that didn't have as much market presence and power, and it's driving ultimately some compression in the reimbursement side of things. So this happened fairly quickly in Massachusetts. The other one that we're paying close attention to that I think is very interesting is the idea of reference pricing. This is the California Public Employee Retirement System, and an experiment that they're doing right now with Blue Shield of California. Basically, CalPERS went to their data and analyzed their costs and said, number one, we can't afford the escalation of health expense across our members. So can we do something about the cost? The answer was working with Blue Shield, yes, and they targeted first through the analysis. They said, we're spending an awful lot of money on total hips, total knees. Can we do something about the cost of those procedures and use that as maybe a stepping stone into expanding this out to different discrete procedures that we can manage variation and manage cost on? So what they came up with, they first polled across the state and said, who's doing it well, who's meeting our quality expectations around total hips and total knees. So that was checkbox number one. Checkbox number two was who would be willing to take a cap reimbursement for total hips, total knees. So the benefit cap was set at $30,000. They signed on 12 organizations across the state that, generally speaking, were close vicinity-wise to a propensity of their members. The caveat, and I think the curveball that was thrown in this experiment, was the patients, if you chose to go out of this narrow network, and really ultimately this was a very narrow network for hips and knees, if you went out of the network and it cost $40,000 for your hip replacement, then you were on the hook for the entirety of the difference between $30,000 and $40,000. So these patients would be paying $10,000 out of pocket, period, end of story. The patients responded. And at the 12 facilities, and this is just 6 months in, so this is just a 6-month number, 6.8% increase in volume at the designated facilities, and overall, the average facility paid per procedure lowering by a quarter. So, CalPERS won, and it moved market share. It begs the question of where to next. So, will they start to expand out to colonoscopies, to cataract surgeries, to outpatient arthroscopy? They're toying with that and rolling out those products in 2000, and they started in 2012 and expanding it in 2013 now to roll those out. So we're keeping a very close eye on this to see how successful this is, because this moved into these markets fairly quickly and could come to the cliche theater near you fairly in short order, 8 months to a year, to put these programs together and have the membership, have it rolled out to the membership as a choice in the plan. So I think this is an important one to keep an eye on. What does all this translate into if we think about the transition to value and managing care in different levels of care and systems and settings of care? At SG2, we do a lot of forecasting, and the story is that and I think you all know this, and inherently you may already be seeing it in your markets, we're shifting towards out of the inpatient environment and to the outpatient environment. And look at the scales that we see on the two graphs here. 40 million at the top of the scale on the inpatient side to billions. So a 28% increase over the next 10 years, 20% of it happening in the first 5 years between 2012 to 2017 on the outpatient side, versus a 4% decline on the inpatient side across the 10 years. So, and I think we've been fairly conservative with this. So in some markets that I've met with recently, they're even more cautious and saying, we think our inpatient volume could be almost double digits in terms of decline based on the demographics and not a lot of movement into the market. You think of someplace like Detroit, where they're seeing still an exodus of folks from the city. Well, their story is much different than maybe in Austin, Texas, where it's booming a little bit in terms of migration of community or migration of into that community. So, where does that? It kind of leads us to a question I think that's important, and that is, what is your product? So if you are a health system, and you think back to that slide where we're inpatient-centric, we've built good channel management, we've kept our physicians happy, the question now is, do we have the right access points to capture the expansive and explosive growth on the outpatient, on the ambulatory side, and on the post-acute side of things? So on the graph that you're seeing here is basically our reflection of that 28% growth on the outpatient side. Where is it happening? And you can see it's across the board, and it's pretty significant in terms of percent growth. And expressively on the virtual side, so e-visits, telehealth, telemedicine, expanding very rapidly in the next 5 years and onwards into 10 years, coupled with, of course, consistent growth on the office clinic side, urgent and retail care side, hospital outpatient, ASC, ED, again, you name it, it is growing, and percent-wise as well on the SNFs, other, and most interestingly, I think, home. So discharge to home and care at home becoming more commonplace across our communities as we're trying to manage care effectively. Now, I know this doesn't reflect revenue, and all the CFOs in the room listening right now are saying, yeah, but our revenue center and our revenues still come from the inpatient side, and I think that's true. And but that said, more and more of the hospitals that I'm meeting with are seeing that their revenue is more where 5 years ago it was maybe 30% outpatient. It's now already moved to 50% outpatient revenue, 50% inpatient revenue, making up the mix of services and revenue stream they're providing. So again, the question for us at SG2 is, and I think for you all, is what's our product and how do we build for tomorrow, and do we have the right systems in place to ensure easy access to the right setting, to the right level of care across our communities, so we can be successful with managing cost of care that's down the road. So building today. Now, it doesn't mean you have to own all of these pieces, but you probably should understand what your capacity is, what your relationships are, and where you need maybe some joint ventures, some contracts, or frankly just a piece of your system of care, owning one of these components. So let's transition to how is the industry responding based on all of those balls in the air versus based on all those things that are pushing you as an industry. How are you responding, and can we learn some lessons from some of your peers across the country? And if you all are doing some of these things, maybe feel free to comment at the end as to how what's your success story, or frankly, where you've possibly stubbed your toe as you're building out for the transition to volume. I think it's important that we put it linearly into some context, because you can only run as fast as the payment mechanism allows you to run. So for most of us, we are in a fee-for-service world. We will be in a fee-for-service world for some time, and we can only afford to run so fast towards value because it's cutting off some of our important revenue. In fact, I was meeting with a chief strategy officer for one of our clients on the East Coast, and she said she had met with the CFO, and they really had crafted a plan to determine where they should focus and how much of a margin they could expose towards risk in building competencies towards taking on value. So for them, it was maybe about a percentage or so of their overall operating margin that they could put at risk on the revenue side to target different strategies to avoid ED visits, to manage maybe their own population of patient or employees, to keep them, to build wellness programs, etc. So I think it's important for everyone to recognize we can't all jump towards optimizing our system and keeping patients out of the hospital religiously on a dime. We can't turn on a dime. We've got to start somewhere, maybe towards the left half of this graph or this slide, to say let's target program development. Let's look at unnecessary care. So for the remainder of the discussion, what I think would be interesting, and maybe I'm a little geeky about this stuff, so is to give you some examples of what people are doing in each of those buckets to either reduce variation and cost in the most straightforward terms, to look at unnecessary care, and that again gets a little bit more complicated in terms of execution risk and the transition to value, down to clinical restructuring and ultimately system optimization. So I have a couple examples from each of these ovals to share with you, and hopefully some of these may resonate, and you can take them back to your organizations and think about, is this right for us, and what kind of value proposition would it be for our patients, given our scope, given our scale, and given our competencies towards managing change. The first example, again, is tied to the beginning of that transition, and that is to reduce variation. And I love this example because Christiana Care in Wilmington, Delaware, looked at this as a way to decrease cost. And since you all, I'm speaking mostly to finance folks, you know the importance of managing sepsis. I don't have to tell you why this was a target for them. It was it's a costly disease, costly condition, rather, that affects us from a couple different vantage points. One is the mortality associated with these patients is tremendous, and the cost to manage these patients is very, very high, and it's very complicated. So Christiana thought about this and said, well, can we develop a sepsis protocol and really look at the goal being to decrease mortality? We did that. They did that by outreaching towards to EMS, to the ED physicians, and worked all together to build a common protocol to identify septic patients earlier and get them into this pathway. They implemented this about a year ago, or a year and a half ago or so, and the results are amazing, honestly. Mortality for septic patients reduced from 62% to 16%, so that's huge, obviously. They benefited financially, and they would just commented on it when we interviewed them anecdotally, but you know it. If you can reduce the rate of septic patients, then and the complexity of those patients, you're saving money. The interesting thing about this example, I think, and the unintended consequence that was a benefit for them, was they were able to discharge to home 200% of the time more. But why does that matter? That matters as they're looking at this as an evolution towards value and taking on more risk. It put the patients in a reduced site of care, reduced cost site of care. So instead of discharging these patients to ventilators and LTACs, they were able to discharge them to home, and much more of a patient satisfier. In fact, any kind of readmission, revisiting the hospital could be managed more effectively, and again, it's a lower cost environment. So a win for Christiana on a lot of different fronts. So I really think this is a great example of how just looking at variation as a cost reduction strategy can be a little bit of a springboard into some of those more complex areas of building competencies towards reducing, towards managing to value. The second example is one of these, I don't know, maybe it's a little tired, but it's what's old is new again. This time maybe it'll work. And this time, at least from the organizations that I've been speaking with lately, it has been working. And WellSpan is one. I'll give you a quick example of something that I experienced firsthand here in Chicago, and that was at North Shore University Health System in Evanston. And this is a centralized scheduling. So they've built something very similar to WellSpan, where it's easy access, one call, one number. You call in. I had something happening with my elbow, needed to see a specialist, and I called one number, set up a appointment, gave them a little bit of information. The lady that was on the phone asked me a couple questions. She said, well, who do you want to see? And I knew who I wanted to see, so I mentioned that. And she said, well, he won't be available for a few weeks. We can get you in 3 days at this other location. You'll have to drive an extra 10 minutes, or you can take the L or whatever, but it's a little bit farther out. So she gave me some options, and I thought that was wonderful. When I presented, so I chose the one that was 3 weeks later, and just between you and me, kind of went back and called the physician and worked around it because I had a colleague that knew him well, so worked the system. But that we'll leave that to the side, as me just maybe, and you probably likely as well, being close to healthcare and knowing how to work the system. But for the average patient, this is a great story. So I presented to their clinic, checked in 5 minutes early, filled out no paperwork. The receptionist asked me, well, has anything changed since your discussion with our scheduler? No, not at all. So they said, well, just sit down. I'd never been to the health system before, so I was new to them, not in their system at all. Just brief stuff they answered. I answered over the phone. And at the end of so I went back, saw the physician, saw the nurse. She took my vitals, made some documentation, made some notes, was evaluated by the physician, got a referral to OT, and left. All within 15, 20 minutes. That was the appointment. At no time did I fill out any paperwork. At no time was it redundant in terms of regurgitating the same information. So in some cases, we tend to, I guess the story that I want to reflect is a lot of when we think about centralized scheduling, we think about productivity, and we think about number of visits per hour, and I think that's obviously important. But for me, it's about managing patient engagement, and managing downstream revenues for family members, for that matter. So I'm sold on North Shore University Health System in Chicago. I will go back to them every time I need to see someone because they made it so easy, they made it accessible, and they made it very, very seamless for me to get in, see someone, and get out. So I think that's really, I think, more compelling for me than it is necessarily about the productivity. So in terms of securing channels and growing the right services at the right settings at the right time, I think this is an important example that maybe this time around the political won't get in the way of the functional, and the IT infrastructure is robust enough that we can build these systems more effectively, and they don't break the bank. So maybe you all have some experience with this. I'd be interested in hearing from you towards the end or down the road as you continue to roll these things out. Now, getting a little bit more complicated in terms of building towards value, here's an example from, it's not Northern Virginia, it is actually more Southern Virginia, Central Virginia, Centera Healthcare out of Norfolk, Virginia. They built a telehealth and home health strategy. So hospital at home, I guess, would be the easiest way to characterize it. And again, I think this is an awesome example. So patients, upon admission, if they were in the facility, in the inpatient status for heart failure, for pneumonia, for COPD, I mean, you can read the bullets, about the fourth bullet down, the conditions that qualified them. If the patients met the Medicare medical or homebound criteria, that was checkbox number 2. And then the nurses and physicians approached these patients and families and said, would you be interested in participating in this pilot? We'll set you up at home. We'll round on you at home with a nurse, with a nurse practitioner, with a physician, and get you set up for discharging directly to home earlier in the process than what we would traditionally consider. What were the results of this? They reduced length of stay across this population of health compared to a similar cohort by 1 day. So that was great. They won on the DRG payment. They won on the home health payment. The patients were satisfied, and I think really the surprise in all of it was the patients were happy, and the readmissions were lower than what you would have expected, or if you did the same peer to cohort to comparative, the readmission rates was lower. So everybody won on this. In fact, Centera is starting to expand this out across all of their facilities, and I think using it as a bit of a marketing tactic to secure market share and to differentiate their services from their competitors. So again, an interesting pilot that really generated some tremendous results for them in fairly short order, where the patients were exceptionally satisfied with this. Another example, again, I think is fairly straightforward, and it's about getting patients into the system earlier to possibly down the road avoid admissions, to mitigate disease and manage disease earlier through screenings, through effectively screening patients. This is an older example, but I love it. So the guy you're looking at the far right on the slide here is called Wally. Is named Wally the Polyp. And if any of you have ever traveled through Appleton, Wisconsin, you've probably come across Wally. He is everywhere. He is on billboards. He is in on the airwaves. He is in the newspaper. He is on their website. And honestly, you can Facebook him, and you can follow Wally on Twitter. And it's all in an effort to increase awareness and to tear down some of the barriers that we see with in terms of screening and colonoscopies. So Wally helps you tear down those barriers and get patients in earlier for screenings. And in fact, at the end of 2010, 21% increase, 21% increase in the number of screenings to 73% of patients screened for in their community for colonoscopies. This is a great example, because they could start engaging with these patients earlier on, and frankly, when on the colonoscopies, you also see that 28% increase in the average number of colonoscopies it performed, and hopefully managing greater disease down the road as these conditions, cancers, etc., are found and caught earlier and can manage those diseases. A little bit more complicated in terms of ED utilization. Sutter Health in Sacramento, in the Sacramento area, that's their headquarters, but they span Northern California. In terms of their system, they found that they were having inappropriate utilization in their EDs. So what did they try? It was a three-pronged approach to managing ED overutilization. And first things first, they started with outreaching to the primary care clinics and saying to them, offering, would you be willing to expand your hours, because it looks like from our analysis we're seeing a disproportionate amount of patients presenting to our EDs after hours. We're even willing to staff your clinics if you'll keep them open. We will put nurse practitioners in those clinics to help expand access at this less expensive level of care versus congesting our ED. So they had some level of success with that. The second thing they did is they looked across the geographies and determined where patients were coming from, and should they be partnering with federally qualified health centers, should they be building perhaps urgent care centers. So they've built 7 in different hot pockets, if you will, to see to try to manage patients, educate patients, to keep them from presenting to the ED. So they've had some success there as the second prong. The third component piece of this, I think, is very interesting. So all of you have probably tried fast tracks before, and you may have one currently, and they probably are working fairly well with siphoning off low acuity patients and seeing them in a different area of your ED. Sutter took that even a little bit, one step further, and they talked about asthma patients in particular, and they noticed that they were seeing a fairly large percentage of patients coming to their ED with shortness of breath, with asthma symptoms. These patients were repeat offenders, if you will, for visiting the ED, especially after hours. So what did Sutter do? They built a specific area within the EDs to treat asthma patients, so a fast track to a specific diagnosis and a specific condition. And why was that important? And the mechanism that helped them be successful with this was they were able to get to these patients more efficiently, number one. But number two is they hired a care coordinator to work in the ED that specifically started working with the patients upon discharge to get them activated with the primary care community and to visit other clinics and other levels of care and set them up almost in a medical home type of an environment to build awareness, to build education, and to get these patients more active in their care. And again, tremendous success. They're very bullish on these approaches, and they're expanding it out to other diagnoses currently. So more to come from Sutter, but I think it's a great example of taking the idea of fast track and other mechanisms and expanding that out to better serve towards the idea of value. A few more examples. And again, these are getting a little bit more complicated. If you think back to that chart, we're getting to the upper right quadrant of the graph now, and this is the Dreyer Medical Clinic, part of the Advocate system in the greater Chicago area. The Dreyer Clinic had been very successful historically with managing diabetes and building medical homes for diabetic patients, building group visits for diabetic patients, building awareness and education for these patients. They've had all kinds of people running the programs. They did an analysis back from about 7 years and looked at all of the conditions, all of the complexities, and what was causing readmissions with these patients. And they came to the conclusion that the best person to quarterback the care of the diabetes patient is the pharmacist, not the primary care physician, not a nurse practitioner, not a PA, a pharmacist. So they met with the physicians. They enabled them to operate within the licensing through the clinic, and the pharmacist could manage these patients directly. They had prescriptive authority. They could titrate medications, and ultimately they became the quarterback in the care of these patients, meaning they were responsible for education, for awareness, for helping the patient manage their disease, to the extent even that these patients don't see a physician maybe not even once a year. It could be even greater than that. And when you come in, let's say your monthly or every couple month visit, you're seeing the pharmacist as your primary care provider. It's a benefit for a couple reasons. Number one, the diabetes patients showed improved outcomes, reduced ED visits, reduced readmissions, and I think more importantly, well, maybe more importantly isn't fair, equally important, the physician workload was reduced. They were able to spend more time with higher need patients. The pharmacists were able to work more at the top of their license, so their job satisfaction skyrocketed. The physicians' workloads, again, spread and increased access, so they were able to be more productive with the right type of patients. So again, an interesting strategy, I think, that led to some really good results across the Advocate system and the Dreyer Clinic. They hired 2, if you're wondering how many physicians, how many pharmacists they have at the clinic at any given time. It's 2 right now. They may be expanding that in the future based on need. Another example from Advocate that you may have heard before, or may have seen some of this happening before, but if you talk to Dr. Shields or Dr. Sachs at Advocate, they would tell you that they are believers of analytics. They live and breathe analytics, and any endeavor that they move towards has to be first founded on what is the rationale, through identifying urgency and need and scope based on reviewing the data and using analytics as a tool. So what they have seen is they had a problem with readmission rates, and this was a couple years ago. They looked across the data. They tried to ascertain what was the issue with readmissions. They diagnosed the issue, and they found that disproportionately they were seeing readmissions happening from skilled nursing facilities, and it was all across. It was across the board. These are skilled nursing facilities that they didn't own. They didn't have any really affiliation with them. They had a loose affiliation, just as a referral source from Advocate. So they got a collective group of stakeholders together, physicians, care managers, SNF stakeholders, personnel, around a table, and they discussed, well, what do you think is causing this issue of readmission from the SNFs? And I think it was fascinating. The consensus from the physicians right away and the nurses was, you don't understand. It's not that complicated. We see them when they're inpatient with us multiple times a day. We're rounding on them. We are active in their care, and we discharge them to the SNFs. And guess what? Their state requirement is that they're seen by a physician once or twice a month post-discharge. So you tell me why they're coming back. It's because we don't have the bandwidth when we get to the SNFs to build specific plans for these patients and to manage and work with these patients to avoid the readmission. So Advocate is in a different situation. They're under full risk in a number of their contracts, so they could afford to do this, and most of us maybe could not. But they looked at the cost-benefit analysis of the cost of readmission versus the cost of keeping them at the SNF, and they found it was cheaper, much cheaper for them to hire SNFists, so the new IS in healthcare is SNFists, to round at these skilled nursing facilities. They pay the salaries of these physicians. They round during the first week of discharge. They have access call lines that they can work that the SNFs can access. The physicians meet with the medical director of the SNFs regularly, and they build plans for managing these patients post-discharge. And in doing so, they've reduced their readmission rates significantly, whereas they're a top performer now in the Chicago area for readmission. Now, again, this is not for everyone and fairly complex. If you can afford it, though, you can run the cost benefit to see if this is a right strategy for you. For the SNFs, it was a win because they really just didn't have the bandwidth or the pocket to staff these types of physicians at their facilities. Other place to leverage to allow physicians to free up time is, I'm sure you all have followed some of this with the Watson's physician advisor. I was struck by the bullets that you see on the bottom here, where 81% of physicians spend less than 5 hours a month reading medical journals. The average medical information out there doubles every 5 years. In fact, I think if I have it right, I believe that 80% of the world's data has been created just in the last couple years. So you think about the influx of data, you think about the influx of material, you think about the how to stay on top of that, and we do need some resources to help, so we're not spending our time trying to figure out versus using algorithms that Watson has developed to diagnose, to create pathways, to consider best practices for treating certain diseases. Watson can process 2 million pages of literature in 3 seconds, and you think about that and what the impact of that would be in terms of managing patients, diagnosing illness, and using that as a tool to improve the bandwidth of physicians. You think about panel sizes, and I don't want to get off track here, but what I've heard from most of you that I've spoken with is you're quickly realizing that right now with the average primary care physician panel size is around 2,000 or so, and you're thinking that in the next couple of years we'll probably move towards with health insurance expansion, with greater outpatient expansion, that 28% I mentioned earlier, that we're probably looking at a 3,500, 4,000 panel size, and we need tools like this to enable our physicians to be successful with managing that increased patient load. Now, if I was with you all face to face, usually by this point, somebody, especially if I'm with physicians, they would jump up and they would wave their hands and they would say, Jeff, yeah, this is all great, but what's the responsibility of the patient in all of this? You talk a lot about what we have to do. Don't they have to change, and how can we get them to be accountable to their own care? And I guess the short answer is, well, too bad. You are responsible for it right now. There are some things happening in terms of value-based insurance design that is compelling patients to change their behavior, but it's a little slow on the uptake. So I have this great example of possibly how we can leverage the perverseness of all of our minds to activate patients in behavioral change and incent patients to change. So envision the world of social media being applied to the primary care physician or to the quarterback in the clinic in managing a patient's disease. So let me give you two examples. One is the idea of anti-charity giving, and again, this is fairly perverse, but I love it. So let's say you're with your physician and you're a smoker, and your loved ones, your family, your spouse, your kids, your primary care physician, everybody is urging you to smoke. You've agreed that you think it's important. You've tried in the past, but it just hasn't really worked. So there is a website called stickk.com. And stick.com will you go online, you go to the website, you sign a contract, you give them your credit card information, and you give them your you set up a password. Anyone from your family or your primary care physician or your whoever you denote as someone that's accessible to your contract can, if they catch, let's say they catch me, my kids catch me smoking out back, they can go online and they can say, I caught Dad. Every time they catch me, let's say it's $10 a pop or $20 a pop, $20 comes out of my credit card and goes to the people I hate in the world the most. So let's say you're a big supporter of the NRA and gun rights. Your money is going the opposite direction. It's going to whatever the foundation is to advance gun regulation across the U.S. If you're a big Mitt Romney supporter, your money was going to Obama. But I think, again, it's interesting. It's an interesting way to leverage something a little bit unique in the world of social media to change behavior. I think I would change my behavior if I knew my money was going to somebody I most despised in the world. The second example is similar. In fact, I have a colleague at SG2 that her fiance is participating in this. It's called gympact.com. And same mechanism. You go online. Let's say you're working with your primary care physician. You need to lose some weight. You're obese. You've tried in the past. You haven't been successful. Same concept. So you go online. You sign a contract with gympact.com. You agree that you're going to work out 3 times a week for an hour each time, or 20 minutes, or whatever it is. And if you don't, it's going to pull each week. If you only go once and your contract said 3 times, it's going to pull whatever, I think it's $10 out of your credit card each time you miss. So if you went twice, it's going to pull $10, etc. The interesting thing about it is, number one, it goes into a pool. So the $10 goes into a big pool that is distributed to everyone that met the terms of their contract. So, in fact, this colleague of mine at SG2, her fiance got a check a couple months ago for $25 because he had met the conditions of his contract, and obviously some people had not. So he got $25 in the mail. I think that's interesting and compelling, frankly. The second, I think, kind of interesting twist to this is you're probably asking, well, how do they know? Well, what have they collected when you signed up for this? They collected your cell phone information. So they can program in through the tracking tools on your smartphone. They can see exactly whether or not your phone presented itself at this gym for the duration of time that you contracted to, or walked this path for the duration of time at this pace that you had agreed to. Now, of course, my wife immediately, when I told her about this, because I like to share these stories with her, because again, I'm kind of a healthcare dork, she said, "Yeah, but I could beat that." Again, that's not really the point, but I think it's interesting to see. Yes, she said, "Well, I can just show up in the parking lot, and I can go from, I could just read a magazine." Well, again, that's kind of defeating the purpose, but so be it. But I think it's interesting that we can leverage technology to maybe incite and look at enabling behavior change in a different way than we could historically 2 or 3 years ago. So can we leverage these types of tools to behavior change? I think yes. And can we think about it creatively to apply to healthcare? I think absolutely. So thinking creatively around patient activation is important. Ultimately, what this is all about is coordinating care, managing care, and it's not about the acute setting as the primary node of care anymore. It's about where patients are coming from, where they're going to, how they're managing their wellness, how they're managing their post-discharge care. And I have across the circle here, so the oval, some of the things that are, and I hope you picked up on the case examples that I shared. What are those things that are bearing the most fruit? And that is leveraging analytics. That's understanding the types of patients and why they're coming to you in the first place, profiling those at-risk patients to get them involved in a different level of activity with you, managing disease, leveraging technology and information systems, and ultimately seamlessly providing that care across the full continuum with different types of professionals, be it care managers, care coordinators, pharmacists, thinking creatively about that to build the system of care most effectively. So just to summarize things, I think, and this is for community hospitals, this would be for rural hospitals, maybe a little bit different twist for a rural provider, and some different types of questions, but some of these hold true all the way down to larger community facilities or large systems. And it is kind of understanding where you sit on each of these questions. What's your vision for healthcare? Where do you see growth? Where do you see demand? Where do you see the propensity for disease? What are the behaviors like of the population of patients across your community that you serve? I think importantly, how you perform clinically, financially, operationally, as compared. And you think about these tiered networks, and you think about steering and narrow networks. How do you stack up to your competitors? If a patient had a choice and they had full visibility to all of those clinical outcomes, financial cost, exposure, operational fluidity, how would you compare? Can you provide access effectively? What's your eHealth strategy? Where are you with your EMR? How expansive is your EMR? And do you have the right personnel to meet the demand for patients in the future? Do you have the right skill set? Do you have the right levels of providers? Where are your gaps, and where do you need to grow quickly, and what are the options that you have? And I think I'll skip down to the bottom. As administrators, what is your role? As CFOs, what is your responsibility moving forward? Is it to manage the acute setting most effectively, to allocate capital and funds and build budgets at the cost center level within the acute center? Is that primarily your job in a handful of years, or are you moving towards something a little bit more expansive and understanding what's the cost of care across our full community, and honestly, what if a patient and their families have a spend per year of $10,000–$15,000 on their health care, what percentage of that is coming to you at whatever site of care that you all have control over? So market share may be redefined as not the number of visits or discharges from your acute setting and primary and secondary service areas, but really what's the share of the wallet that you're seeing across your full continuum of care, and are you missing opportunities to build out that system of care more effectively to secure a revenue stream for a number of different reasons to help you financially manage margins down the road as you see those transitions. So that is the information. I hope it was useful for you all. And let me pause there. We've got about 10 minutes or so left, so we can either adjourn earlier or I can answer questions if you've got specific questions that I can maybe field for you all. So let me open it up for any questions that you have.
Okay, Jeff, this is Craig again. Let's say, here's a question. Given the front-end expense required to transition to a risk model, can an independent rural hospital survive without a partner?
That's a very interesting question, a very good question, and one that I over the last few weeks, I've had the pleasure of being with a number of rural hospital meetings through different hospital associations, one in Maine, one in Georgia, and one in Tennessee just earlier this week. And it's top of mind for a lot of these executives from rural health. And I think, as I kind of batted the idea around with especially Tennessee earlier this week, it's a difficult lift, honestly. It's a lot of money that they don't have. It's a lot of coordination that they don't have the capability to do, so I think it's problematic. I think it's very difficult for a rural facility that's independent to move very quickly to the notion of value very rapidly without the deep pockets. So not that it's undoable, but it's going to be difficult. It's why I think you're seeing some of the activity that we're seeing. For example, the LifePoint Duke joint venture, where they are a for-profit system with deep pockets partnering with Duke to buy hospitals across the country. They're looking at some rural providers. They've expanded into Michigan. They started in North Carolina and Virginia, expanded to Michigan. And in fact, I think they put in a bid, and I think we've got some folks from Florida maybe on the phone. They expanded into Florida and put up a bid against the University of Florida, and I think it was Community Health Network as the competitor. So I think that's enabling some rural facilities to access capital to advance their cause more efficiently and timely. The other, I think, qualification or maybe good news to that is, in a lot of cases, the rural providers have an ability to coordinate care more effectively just because of the relationships of the community to the health system. It's more of an integral part. They're maybe the sole player in town. They do see the health system or the hospital there as a resource and an advocate for them. So there's the opportunity to control and move towards wellness exist more opportunistically in the rural setting than it does maybe in a larger setting. I think the answer is yes. So maybe some good news and bad news for that tactic or strategy.
Okay, and again, just a reminder, if you have any questions on the toolbar there, please go to the question area and you can type in your question and then either send it privately or send it to all, and we'll definitely ask those. Okay, let's see, here's one. Any thoughts on how gained risk money can be shared among different tax IDs in an ACO?
Boy, that's a good question, and I honestly don't want to misrepresent myself as somebody that is could give you that kind of advice as to how that would play out. I think it's a matter of working with your legal teams to determine how best to allocate and build the contracts to distribute any shared savings across those discrete entities. It is doable, of course, but again, I don't want to misspeak on that.
Sure. Well, how about this one? The ACO model seems to be maintaining momentum. Do you think this will continue? And then the second part, is this a stepping stone to a more traditional capitation model?
Well, I think a lot of the CFOs in the room with us probably have a strong opinion on that. I think there's still a healthy level of skepticism out there as to whether or not this will work, especially given the current payment mechanism as founded on the fee-for-service chassis to be successful as an ACO and share savings. So, in fact, I was with one of the pioneer ACOs just earlier last week, and they were asked the same question of, well, you did a great job the first year. How much juice is in the lemon, and how much can you squeeze? Because they're going to reset the savings bar every year, right? And they said yes, but for them, they thought there was enough opportunity that they could continue down this path in reducing overall utilization, overall cost, and share it significantly enough in the savings. What they really were focused on was expanding the base, expanding the number of participants in their ACO endeavors. So I think the short answer is it's going to continue. I think it is a stepping stone into something greater, though, because there's only so much you can change if you're still under, and so many stakeholders you can pull into this if you're still under the framework of fee-for-service. So I think that ultimately has to change for us to evolve the industry a little bit more aggressively towards managing the costs. It's probably maybe let's say we'll see the results after the 3 years are up from these pilots, and probably a determination at that point as to if we're going to continue down that path, or the industry is going to shift to something a little bit more aggressive.
Okay. And then another question here. What is the best way to determine what payment and care delivery model that your hospital should adopt? You probably need a couple hours to answer that.
Yeah, that's a great question. I would put it into maybe a couple different lenses. One is what's the physician community and the hospital's appetite for risk and the aggressiveness of the risk. You may want to start with something a little bit more simplistic, just staying with fee-for-service and paying for care coordination, and dabbling very, very slowly. Again, it's based on how the community perceives you. I'll give you a quick maybe example of that. So I was with I believe it was in Tennessee, a hospital CEO, and this was about a year and a half ago, I think, and they were asking the same question, and they said, yeah, we're ready to jump into risk. We think we can go into some capitated model with our commercial payers. We think we can participate in the Pioneer program from the ACO, from Medicare's side of things. And I asked him why he thought that, and the answer was interesting. He said, well, we're just ready. We've hired our physicians, so we're aligned. We've got an EMR, and so we're ready to go. And I said, well, it's interesting that you say that, because really, I don't want to be disagreeable, but when you drive into your facility, all you see is kind of billboard after billboard that advertises how easy it is to get into your ED. In fact, you can schedule into your ED. You can see the flashing white light that says right now 2 miles away at this ED. It's only a 5-minute wait. Come one, come all. So it may be that they've got some alignment things in place that are going to lead them to success, but it's not going to be overly successful in the long run until they get the perception of the community to change. So they need the patients and the education of the patients and the community members to say, look, we understand where we should go to access care, and have the physicians bought into that too, and maybe some of those strategies like Sutter did that I described earlier can help them along the way. So I think it varies based on your organization's readiness to manage risk, and where the market is in terms of pushing risk, and then where the culture of the community is in accepting different models of care and different payment mechanisms supporting that. I probably didn't answer the question, but I think it would take a little bit of time to really get into that specifically.
Okay, let's see. I think we're about out of time, so we'll go ahead and just kind of wrap things up here. But again, thanks, Jeff, for speaking with us today on the evolving landscape of our healthcare delivery system and sharing many examples of how providers are working to redesign, I guess, different care and transitioning to the value-based delivery model. So really appreciate your time for coming out and speaking to us today. And for all the attendees, we appreciate you for participating. Again, you'll receive an email with a survey, so we please ask that you'd complete that so we can get any comments on that and possible future topics that you would like for us to cover. Again, this is a combined effort of the 5 states in our Region 5. Alabama was hosting this one this month, and Georgia will be hosting another webinar next month. So there'll be some more information you'll receive through an email probably in the next couple of weeks about the date and the topic with that one coming online. So with that, we'll stop the broadcast here. And again, thanks for attending. Hope you have a good afternoon.
Thank you.